Hello, my name is Maretta Reidimo. I'm an occupational doctor from Finland, Helsinki, and I'm going to tell you about chronic pain, and then I'm going to tell you about our study, which is called The Effects of Pain Management Group on Chronic Pain and Pain-Related Symptoms. During this lecture, I'm going to go through some subtitles. First, introduction, then risks and preventing factors for chronic pain. After that, central sensitization. Then I'm going to tell you about non-pharmacologic treatments and pharmacologic treatments of chronic pain. And then I'm going to tell you about our study. And in the end is summary. Chronic pain is quite common. Chronic pain is defined as pain lasts at least 3 months, and it affects from 19 to 42% of world's population. And chronic low back pain and migraine are the leading causes of disability. Surgery is risk for chronic pain. From 10 to 30% of patients who have had surgery will have chronic pain. Also, trauma is risk for chronic pain. When pain is avoided, and that leads to muscle tension, which is long-standing, and muscle ischemia, which is painful state, and if this goes on long time, that might also lead to chronic pain and central sensitization. Also, physically demanding job is risk for chronic pain. Low level of education and housing deficiencies are risk factors for chronic pain. Also, traumatic childhood. Traumatic childhood can lead to hypothalamic pituitary adrenal cortex axis disorder. And if person who has this HPA axis disorder has psychosocial stress, then nuclear factor kappa light chain enhancer increases that triggers genes encoding inflammatory substances like interleukin 6 and interleukin 1. Also, cortisol level is very low, and all these changes lead to pain and may also increase risk of chronic pain. Moderate activity only 2 or 3 times per week reduces pain and depression, and so may be preventing factor for chronic pain. Also, positive affect optimism, psychological resilience prevent chronic pain. Here is a picture from Edwards et al. And it presents psychosocial processes in the development and maintenance of chronic pain disorder. Acute pain can change to chronic pain, especially if person has distress, trauma, fear, or catastrophizing thoughts. On the other hand, protecting factors are social support, active coping, acceptance, and self-efficacy, and they prevent acute pain turning into chronic pain. Current chronic pain research has shown that the pain inhibitory system and the supraspinal descending pain control pathways function altogether and in balance. But injury, inflammation, or illness such as temporomandibular disorder, rheumatoid arthritis, or fibromyalgia, or long-term opioid treatment over 1 month may disturb this balance, and that leads to chronic pain. Central sensitization leads to weakened brain-established descending antinociceptive function, which is pain inhibitory, and also overactivation of pain-increasing pain facilitatory pathways, which is called wind-up. Both ascending and descending system are overactivated in central sensitization. Here is a picture about central sensitization. Pain can be in one spot or a larger area. Pain signals move through the nerves and up to the spinal cord and up to the brain. Brain reads these pain signals, but body can't protect itself and decrease pain because brain can't produce enough endorphins to control pain and relieve pain, and pain may persist and be harder to relieve. Here I present some non-pharmacological treatment of chronic pain. Non-pharmacological treatments can be exercise, psychotherapy such as cognitive behavioral therapy or mindfulness therapy, as well as physiotherapy. Cold and heat therapy may be relieving chronic pain. Also, subcutaneous nerve stimulation, massage can be relieving for example, headache and neck pain. Also, other pain. Kinesiotyping, acupuncture, mirror therapy can be effective for chronic pain. Water exercise can be effective for chronic back pain. Also, guided aerobic and strength training is effective for fibromyalgia pain. Tai Chi is effective also for chronic pain like arthritis, osteoarthritis, and rheumatoid arthritis. Sauna therapy may improve quality of life and reduce pain in patients with low back pain. Also, dance-based intervention programs have proved significant reduction in fibromyalgia pain. Chronic pain research proves that chronic pain thins the gray matter in the brain. Zen meditation has proved to increase thicker gray matter, and also hatha yoga practice regularly has proved to be effective in increasing amount of gray matter in the brain. Usually when chronic pain is very high, non-opioid drug therapy can relieve pain for example 30 or 50% after 1 month of using this drug, and after that patients are usually willing to start trying some non-pharmacological treatments. It's suggested to continue this medication for 3 or 6 months, but also some patients need 1 year medication or even more. And duloxetine can be used. Also amitriptyline can be used. Even 10 milligrams of amitriptyline can be effective if patient has, for example, insomnia. And usually when insomnia is relieved, also pain is relieved. Also pregabalin can be used, or venlafaxine can be used. In chronic pain guidelines, usually recommend to start non-pharmacologic treatment, and if patient has insomnia, depression or anxiety, especially then non-opioid analgesics are needed as combination. Next, I'm going to tell you about our study. Our research questions were efficacy of pain management group on pain symptoms and pain-related symptoms, as well as ability to work, also on sick leave and for use of health services. The study population is from Helsinki City, occupational health services users. Helsinki City has more than 40,000 employees. The study is also based on survey collected in 2001-2002, when about 25% of Helsinki employees reported suffering chronic, more than 3 months lasting pain. My supervisors for this dissertation are docent Ari Kaukiainen and docent Markus Sainio. This is randomized controlled trial with stepped wedge model, and inclusion criteria were 18 to 60 years old, who has pain at least 3 months and also has elevated risk for work disability, which was screened on modified Örebro questionnaire. Exclusion criteria were under 3 months lasting pain, also some malignant illness or severe mental illness, or patients who are currently on some other pain crop. "60 participants were randomized to 2 crops. 3 pain management groups started immediately, and each group had 10 participants. 30 participants were on waiting list, and they waited for 3 to 4 months for new pain groups to start. Content of the pain management group was biopsychosocial nature of pain and principles of cognitive behavioral and acceptance and commitment therapy, as well as relaxation techniques and mindfulness skills. Here I present the content of the meetings. Before every meeting we had coffee break, and after that short relaxation or mindfulness exercise, and after that discussion about some theme, and also there was some free discussion. For example, participants were able to bring out some ideas how to relieve pain or which kind of pain management tools they had in use at the moment, and also some other things they wanted to discuss. And also there was this homework, and homework was discussed every meeting after participants had done homework at home. Here I present the collection of results. The primary outcomes were pain intensity, pain self-efficacy, chronic pain acceptance, depressive symptoms, insomnia, fear avoidance beliefs, current work ability, number of occupational health care contacts, expected development of work capacity over the next 2 years, also sick leave, which was measured from city's personal register. Here I present some results from the study. This is a distribution of subjects according to the number of pain areas. Pain areas were 10, and before intervention average number of pain areas was 6, and after intervention the number of pain areas decreased nearly half from the beginning for 3.6. Here are some more results. Pain was decreased 19% after intervention. Number of pain areas decreased 40%. Stress symptoms decreased also 16%. Depressive symptoms decreased 20%, and insomnia symptoms decreased 29%. So this intervention was quite effective. Also, pain self-efficacy increased after intervention. Participation in group meetings increased mean pain self-efficacy statistically significantly. Before, mean self-efficacy was 30.4 and after 37.5. So mean self-efficacy increased 23%. Here I'm going to go through some summary topics. The pain increases if patient has sleeping problems. Also, if patient with pain has depression or anxiety. Fear and fear of movement also increases pain. The feeling of self-efficacy reduces pain. So, if insomnia, anxiety, depression are treated and self-efficacy confirmed, pain decreases. Greetings from Finland. This picture is from Lapland. Thank you. Bye. Take care.